for everybody out there, this is a Compass MS Care program provided by MS Views and News. I am president and founder of MS Views and News. Sponsoring today's program is EMD Serono, Sandoz, Genentech, Biogen, Banner Life Sciences, Bristol Myers Squibb, Sanofi Genzyme, and Novartis. All of these companies, all of these pharmaceutical companies are greatly behind the programs that we provide because they do make an impact. So I'm glad that you're all here today to be able to see this. Fortunately, also, we had some exhibitors out here. It was very hard for the exhibitors to get to this location, but we had Bristol Myers Squibb, Alexion, and Banner Life Sciences. So again, let's give our sponsors a nice welcome. Thank you. All right. Again, everybody in attendance, thank you very much for being here. Right now, though, I want to introduce our speaker of the night, and this is Dr. Sam Hunter. And Dr. Sam Hunter speaks at a lot of MS Views and News programs around the country, and he is the lead medical director, of course, of the Advanced Neuroscience Institute in Franklin, Tennessee. And believe me, you're going to learn a lot from this guy tonight, all right? And if you don't have enough questions for him, I'm going to be angry. So make sure you get questions, okay? Great. Thank you very much. Take it away, Doc.
Okay, so we're going to talk about decision making and how to do that. We're going to talk about a few new MS treatments, but we have a lot of generic therapies that are coming to market right now. How do you deal with that when you've been on MS therapy and you're trying to learn how to do that? We're going to talk about access to MS care. COVID is kind of mostly over. It's evolved mostly into a much less severe virus, which is wonderful. It still is unpredictable, and if you have questions in that regard, I'm happy to answer them. But we're going to talk about how to measure your MS, your cognitive issues, and how we, in generally, try to monitor you. You can even do this yourself in healthcare. Can we go forward, please? Okay. I'm going to dedicate this to a friend and patient who was very long-term, who passed away from COVID, and not because she didn't try to do everything right. Next slide. All right. Let's talk about it. You're up against a difficult situation with MS because half of the specialists who are tasked with caring for MS, they really don't want to care for you. Some do, and some are wonderful, but finding your way to that person and having the opportunity to have that kind of a team that's led by a person like that is really is really a challenge for many people. You might have heard some of these phrases. I trained at that really big, well-known healthcare institution that's in the next state over. Which I understand it runs a lot of your healthcare, and a wonderful place to train and a wonderful resource. But I heard this a lot of time. MS isn't so bad, but there's the other part of that is for the first 10 years, but the rest of your life depends on that first 10 years. A lot of doctors try to talk people out of therapy. They say things like, MS, many people are benign. In reality, less than 5% of people are benign, and the benign people just walk well, okay? They're like Paul. Maybe you never had MS. A lot of doctors will pull this one out when they don't want to bother with you or treating you. Maybe you didn't have MS. Maybe, I don't think you have MS. They'll pull this out and you're like, did you look at my records? But this happens all the time to people, especially when the doctor changes or they change doctors. The latest popular one is your MS is burned out. You're 50 now. You're 55 now. You're 60 now. You're 40. Everything's been going well for 5 years. Your MS is burned out. It's not going to give you any more trouble. This is definitely not true. It's almost a religion that people adapt so that they don't have to deal with you. I can't do anything about that. Nobody can do anything about that. All I can tell you, it's better in America than it is in the rest of the world. In America, you would prefer the MS patients get 30 or 45 minute slots. In reality, they get 10 or 15 minute slots at the doctor. That's better in Great Britain. In Great Britain, it's 3 minutes. If you're really sick, it's 6 minutes. In Germany, it's 8 minutes. They're very generous in Germany and Switzerland. In Italy, it's 5 minutes. All right. In Canada, it's 5 minutes, except the first time you get an hour. So you better look out for yourself when you have MS. And I'm going to tell you a little bit about how to look out for yourself and some of the information. So when you choose treatment, disease-modifying treatments, or any other medicine for any other disease, we look at 4 big factors: risk, benefits, costs, and convenience. We'd love to have a medicine that has no risk, cures the disease, doesn't cost anything, and is easy to do. Medicare calls that a treatment that costs nothing, and that doctors do it for free. It doesn't exist. So you have to compromise among these things. So you end up with some centers that operate with very expensive treatments for their cost and convenience that may not even be safe, using it for everybody because at least they get paid. You have some neurologists who will only use exceedingly safe medicines, but they're very ineffective for the majority of patients. They may work for some, but not for everybody. A good neurologist is going to try to fit the medication to your situation, the risk you have, and your treatment history, and that's different for every person. Although there are some generalizations, and especially early in treatment. Next slide. All right. So how do you look at it? Well, you as a person with MS have to agree with whoever's treating you, the team who's treating you, understanding where you've been and where you want to go next. And the benefits of our medicines for MS are largely what never happens. So what never happens if you have brakes when you're going downhill, okay? Well, you don't crash. We want to prevent the crash, all right? You may still have a little slips or a little trouble, but people value different things. A lot of what drives you as an individual is different from what drives the next person. Losing your abilities, medication complications, well, you gotta put more emphasis on one or the other. You know, people who are not doing well need to tolerate higher risk if they want to control their disease. On the other hand, we want you to sleep at night, so we want you to understand your medicine. Part of that is there are really risky treatments. We don't use them as much. There are less risky treatments. Those are probably safer than driving to the doctor on the highway. Losing your picture of yourself, well, having a chronic health problem and MS and something that's wrong in the brain is something that you learn to accept. You learn to accept that, just like a lot of the limitations. But the younger you are, the harder it is to accept those things when they happen to you. We all want to be in control. And getting control of your disease is the best way to get control of your destiny. Lifestyle things are important. It's really hard for some treatments and for some people. And we try to respect that. And the financial stress and financial support that comes with expensive treatments is very important. So what I run into as a physician when I'm trying to treat people is that some people are so scared of risks that they don't adequately treat their MS. They either won't treat it at all, or they only want really ancient medicines, which are great medicines in their day, but they're just not as effective or as safe or as convenient or as reliable as newer treatments. Some folks will take a lot of risk because of their fear of MS. And there was a very well-known person in the media who did this recently, who went out of the country and got a treatment that's not considered as safe because a few percent of people die when they get the treatment. And the way you deal with that is you go to people who tell you, oh, well, it's safe if you get it from us, and they don't do it as well as other people, perhaps. And the reason why those treatments are not used is because we have other things that work well, which don't have those safety issues. Drugs like natalizumab, which has been a godsend for people with difficult MS, is not as safe. But it's really the exception to our MS medicines, not the rule. It works very well. If it was safer, we'd use it for far more people. Some of our safest medicines have some unpleasant side effects. Some of our most effective medicines have some unpleasant side effects, but that doesn't mean they're dangerous. That might be something we have to learn to work around, if possible. And many of our medicines that have lots of risks listed really in practice are pretty darn safe, and it's rare that anything goes wrong with them. So you have to think about in terms of relative risks. So if I said to you, this treatment has a 2 to 5% risk of you dying from the treatment, what is your risk of dying from MS? It's practically zero, believe it or not. People die a little bit younger who have MS, and MS is more deadly than some diseases, but diabetes is twice as deadly as MS, all right? And who thinks that they're dying from diabetes? Nobody. You know, it causes a lot of health problems. But you need to think, if you get certain treatments, that this is your risk. What's your risk? What's that risk? 2 to 5%. Anybody here a gambler? What's the risk of rolling snake eyes? Okay, so same risk. Rolling snake eyes, all right? A 2 to 5% risk of a hospitalization in the next 5 years. How big a deal is that? Well, people with MS wind up in the hospital all the time for one reason or the other, but treatment, an effective treatment, a highly effective treatment, might put you in the hospital for a few days. Is that worth the risk? If you've got difficult MS, that's certainly worth the risk. What about 1 in 5 or 10,000 risk of dying with your effective, easy-to-use, safe, well-tolerated medicine? Well, that's the risk of most of our MS treatments right now. That's a pretty reasonable trade-off. And so it's not something, unless you're really prone to worrying about things, that you need to worry about a lot. The normal risk of dying in a traffic accident is about 1 in 100 in your lifetime. 10% of women in the United States will get breast cancer, all right? Breast cancer is less deadly than MS, though, believe it or not, because it can be cured. The normal risk of death from a cancer is normally 1 in 1,000 every year. So every person in this room has a risk of 1 in 1,000 of dying from cancer in the next year, not because they have MS or they're on treatment for MS, but because they are breathing. All right. So what do I think about? What do other doctors think about? They think about these factors, some more than others. I've told you some people are about risk. Well, the insurers are all about whatever their policy is, which mainly has to do with cost and how much money comes back to them under the table as rebates. They tell you, oh, your treatment costs $100,000 a year. No, it didn't. It didn't count the $25,000 the manufacturer had to pay them back in order to get them to permit them to use their drug. So there's this nebulous factors you can't measure. But everything here is about how we decide to treat people. And so when you come in and we're looking at first treatments, what do we want? We want something with low risk that they're going to approve, that you're going to like, and isn't going to interfere with your immediate plans, which in usually younger women with MS has to do with childbearing. And we try to avoid drugs that have a really big liability for fetal injury. So prior treatment failures control a lot of the further decision making that you're going to make. If it was a treatment failure because of tolerability, we're gonna address that. If it was a treatment failure because the drug isn't working, or with your with controlling your relapses or worsening MS of any kind, then we're going to look at another class or a more effective therapy. We generally think of MS therapies in 3 tiers of efficacy. Frontline efficacy, which was the traditional amount. There's one other drug that is a newer drug that's oral that's about the same efficacy. That drug was called Aubagio. It's going generic as we speak within the next couple months. That drug is about the same effectiveness. Then we've got some other oral drugs that are more effective. We call them kind of tier 2. They're more effective. They're mainly oral. There's an injectable drug that's out there now that's in this class. And then we've got highly effective drugs, which people sometimes call chemotherapies. Sometimes we just call them more highly effective agents. These are drugs like Tysabri, Ocrevus, and Lemtrada. And there are older drugs that are chemotherapy drugs that we don't use much anymore because they're safety. All right. So my simple wisdom is this. Doctor's advice is cheap. disability is not cheap. What you lose, you will not usually get back. There are exceptions, but very few, okay? And we have very highly effective medicines that will return some function in some people, but you can't expect that or be guaranteed to that. What you can be guaranteed is highly effective medicine will protect you. When we talk about highly effective medicines, we're talking about an 80% chance that 10 years from now you'll be the same or better. That's a highly effective medicine. And there are very few medicines that can make that claim. And in fact, doctors hate using those medicines because they're a lot of work. Insurance companies hate using those medicines because they cost a lot of money, and they would do anything possible to avoid using those medicines with you. But if that's what you need to get it. All right, this is not meant to be a vision test to see if you can read this slide. This is to show you the number of medicines, and they're actually, after I look at this, I always add another one that we can use to treat your MS disease. First of all, there are a few that we just use for relapses. But these are other immune therapies that we use to prevent disease. The old ones, the new ones, the strong ones, the weak ones, the ones that are no longer approved or removed from the market are gone. IV immune globulin, and up here, we don't use that very much. But there are medicines that are not approved for MS that we actually use for MS because they're cheaper or more appropriate, or kill two birds with one stone, or three birds with one stone. I have a drug that we use temporarily that treats people's acne as well as their MS. As a bridge, so that when one medicine's wearing off before another one doesn't work, we'll use that. But there are many treatments here that are basically best grouped into classes, and we call them by their class. The more recent therapies that you see here, the methylfumarates, are ones that were originally called Tecfidera. Now that drug is called dimethylfumarate, or DMF for short. This is a cheap medicine. If you can take this medicine and it works for your MS, it's an ideal medicine. It's twice a day. But 25% of people get a horrible bellyache from it and can't take it. And the generic ones might not be quite as good as the brand name, but they're good enough, I guarantee you. But other companies have made better versions of these drugs. They're brand name medicines, Vumerity and Bafirtam. They're both very good products, and they're actually simpler to use than this one. S1P agents, these were originally, the only one in the family was Gilenya. These were invented from Chinese herbal medicine, and these companies spend billions of dollars to tweak these things, and every one of these drugs has an advantage and a disadvantage. Here's Aubagio leflunomide, is that cheap generic drug that we've had for years for rheumatoid arthritis that many people use for MS. But then we've got biologics, which started out as Rituxan, that we don't use as much for MS anymore. And then we've got the other drugs that were specifically approved for MS, which are monoclonal antibodies. Symptom's probably not as strong as Ocrevus. It's the same family of medicines, but it's an effective medicine too. And like I said, we've got even drugs that are lightweight chemotherapy drugs, like Mavenclad, that will stop MS for years and years and years in many people. And so you have more options than ever before. There's no reason. I think older people have a hard time convincing their doctors about the need for therapy. You should be very upfront that if you've had some close calls with MS and you've been able to hold the line against worsening disability for many years, you have to insist on treatment, because this myth of older people don't need treatment is really severe, and this has been studied. There's been many research studies. They all show that if you stop treatment, you'll have many times the rate of new problems with your MS. And for someone to say it doesn't matter is really quite against the data. All right, so what do you do when your medicine goes generic? They are not cheaper to you always. So some of you are taking Aubagio, some of you are taking Gilenya. In the next few months, you'll get a call from your pharmacy that may say something like this: "Hi, there's problems with your copay assistance. You're not going to be able to get it anymore. And you'll say, why? And you'll say, because the manufacturer doesn't give it. And you'll say, why? And they'll say, because you're getting a generic medicine now. And you're saying, really? How much does it cost me? How much am I saving? And they'll say, well, your copay is about $4,000. Okay? All right, well, so the manufacturer had been paying this for you and also had been rebating the insurance company many thousands more dollars up to the point where a competitor was allowed to come in the market. And with the FDA, when someone loses a patent battle, they allow somebody to do that. And 6 months later, they allow everybody else. But the first 6 to 12 months, when there's only one competitor, it's only a few $1,000s cheaper. And the drug company that made the original drug wasn't stupid. They raised the price for a while. So when that competitor comes in, they don't lose as much money. Is that good for you? No, that's just the way the business works. They have a limited set of time. And then 6 months later, 20 companies make the drug and the price comes down. Did that happen with Tecfidera? Sure did. The first year it was terrible. We had a hard time keeping people on drug. Now you can go to Walmart, $200 for the drug with a coupon, not through your insurance. You call your insurance company, you say, I want the drug. They say, oh, your copay is $2,500. It's all about contracts. It's all about a market. Biologics will never get that way. They're very expensive drugs to manufacture. So the older drugs for MS are quite expensive, the interferons and glatiramer acetate, which is really not a biologic drug, but it has to be made in a certain way that's almost like one. And then the monoclonal antibodies, so you hear those advertised on TV. And we have other newer drugs that you can switch to. We have drugs in the S1P family. One of them was being advertised out here tonight. If you're going to have trouble, if you've done great on Gilenya and you can't afford Gilenya, get your doctor to put you on a drug like that. The manufacturer will help you. You just got to get the insurance company to approve it. You have to have a reason why you can't take it other than you can't afford it. Oh, I couldn't get the drug. Oh, it tasted terrible. Oh, that drug made my vision blurry. Okay? That drug gave me a headache. That drug raised my blood pressure. That's a good reason to change. Okay? Insurance companies aren't all knowing, and they really don't care as long as you took something else before. That's how you deal with these generic problems. You should consider the opportunity, if your drug goes generic, to try generic drug that's already out there, like generic dimethyl fumarate, if you haven't tried it and you don't know that you can take it. Generic dimethyl fumarate has lots of side effects, but 75% of people can take it just fine, and it works pretty darn well for those people, but not for everybody. So figuring out with your healthcare team what the right thing is to do is something you should do. But it's not the end of the world when there are this many choices. And there will be many generic drugs that are very inexpensive within 3 years. All right? All right. So 4 S1P medicines, 3 methylfumarates. If you want to take a methylfumarate and you're forced to take these generic one and it has too many side effects, take another one. Try another one. The company will help you do that. You can try it in a few months. You can see if you can take it. If you can take it, you go to the wall with the insurance company. You call and you make a complaint. If they won't let you have a drug that works well for your MS and you tolerate, you file a grievance. This is a formal process. They will do anything to get you off the phone before you do that. I filed a grievance against the telephone company last month. I got a call from the governor's office today and the president of the telephone company when I filed a grievance. They take it seriously when you do this. These are people who the government is watching them. And if you file a grievance that they're doing something unreasonable for you, you will likely win. It may take a year, but you'll probably win. All right. Biological medicines are things like vaccines and monoclonal antibodies. They do not go generic. They have generic brands or generic like competitors, but they're all approved individually. And they're much more expensive to manufacture. The FDA has to approve the factory. The FDA has to approve the drug. It's very rigorous. And so they always cost more than chemical drugs like the other simpler drugs that any chemical company in the world can knock that off. You can't knock off a biologic easily. There are biosimilars of Tysabri coming. There's already biosimilars of Rituxan if you're one of the practices that uses Rituxan for MS. There are these other drugs. They're all in the same family. What do? Well, all these anti-CD20s, these are drugs that paint certain immune cells with a marker that causes the immune system to destroy them, okay? Tysabri actually is a little different. It just makes them slippery. It doesn't remove them. It makes them slippery so they can't get into the brain. And the old one, Lemtrada, it paints all those immune cells in that family, and the immune system just kind of does a house cleaning. And that's how these things work. There's a chemotherapy drug called Mavenclad that's out now that does this in a lighter way with a drug that would be considered chemotherapy, but such a small dose that it's not a big deal for most people. These are all medicines out there that you should consider treating for your MS, especially if you're not doing well or you need to change treatment. There is some new medicines coming. They're called BTKIs, or Bruton's tyrosine kinase inhibitors, not bind, torture, and kill like the guy who was doing people in Kansas. But these are drugs that show promise in treating autoimmune disease. They're anti-inflammatory agents. They've been very successful medicines in this family for related diseases like psoriasis, rheumatoid arthritis, and Crohn's disease, which you hear them advertised on TV. All these things, they're called TNIB. On the end, these drugs that say TNIB. There are two of the companies that could have these drugs in 4 years for MS. Are you going to take these drugs? Well, if they prove a whole lot better than the existing drugs, you might get to these drugs. But if your MS is well controlled with existing drugs and you're tolerating them, there's no rush to change. Some really fantastic ideas for MS are in progress. We are testing drugs that we've never known before. In fact, to call them drugs is a little different because they're really, in some cases, cells that we put into people's nervous systems, like through a spinal tap, or we give them IVs with immune cells that are trained to hunt down the EB virus that we know kicks off MS. We don't know how well these things work. We'll find out. If you have the chance to participate in a research study, you should do it because that is how we learn. I call it donating your brain to science while you're still alive. How's that? I'll have a t-shirt. You can buy it. Let's talk about decision making. So let me give you a few examples. So Julie was a patient who came to the office and said, I want a stem cell treatment. I'm tired of these MS treatments and their side effects, and my insurance company never lets me have what they want. I mean, I don't immediately come back with the thing, well, they give you, it's really chemotherapy, and they're going to kill your immune system, and they're certainly going to kill your hair at the same time. And if you survive that, and 97% of people survive it, have a close brush with death if it's done right, every one of them, because they get a fever when they have no immune cells. They're going to die if they're not in hospital. So, she said Selma Blair had one, and we hate to ding other doctors, but I would not go to Mexico and get that. If I thought those people knew what they were doing and did it well, I would tell everybody to go there. What Julie knows is very little about this process. She also told me in the same conversation, she bought a timeshare in Florida. All right. What she doesn't know is that these things don't work, that you lose your life on occasion. People don't tell you this at these centers. We actually have very good medications now. We've never had this kind of choices, and we can usually find something that's going to slow it down. Is anything going to cure your MS? Nothing will cure your MS. there are treatments that work so well that if your MS comes to a crawl or a smoldering or a complete standstill, that's the biggest win we've ever had. And we have more of those situations happening now than we ever have had. And you can always send somebody to that big medical center east of here a ways that will talk to people about options. But I think if anything, they try to talk people out of treatment sometimes, and because they're doing well. And let me tell you, if you're doing well and you've had a lot of MS treatment, it's because of the MS treatment. Although some people are really lucky, and the odds are not with you if you've been lucky. All right, let's talk about another decision making. What about PML? What is PML? If you don't know what PML is a rare brain infection that you usually get because you have a cancer or HIV, because the immune system has let a common benign virus run rampant in your body to the point where it mutates into a virus that can infect your brain, and it eats your brain, all right? This is bad. This is always bad. It's never good. It's a catastrophe if it happens to you when you have MS, because we have to let your immune system get that virus out of your brain. It's listed as a side effect of most of our effective medicines for MS, even though with most of them, it's never happened. All right? Why is that? Because the wise people at our FDA think it's a potential to happen, even if it's never happened. And if somebody ever thought it might have happened, they're going to blame whatever medicine people are on at the time, not the medicine they were on before that, or before that, or before that, or their leukemia or whatever else they happen to have that was the real reason they got it. So we have a lot of people come in who are afraid of this. You know, there are some people who are programmed to be afraid of things because that's what kept their ancestors alive. You worry about, you know, what's going to happen tomorrow and if it's going to rain tomorrow and everything else. And if you're like that, sometimes you can't stop thinking about this catastrophe that could happen with this rare problem. Well, the treatment for many of these things in MS and in MS problems in general is understanding it. And the PML risk is very clear, and it's really only a risk of this drug, Tysabri, which is a highly effective drug for MS, and people feel great taking it, but the risk after a year is 1% a year, which means if you're on it for 5 years, it's about 5% risk of getting this catastrophe of a brain infection that often leads to death. And almost all this occurs in other diseases to people. Almost all the cases of PML occurs in other diseases because people had this drug right before they were on the other treatment. So every one of our treatments looks like it causes PML to the government because they got Tysabri within the year. Now, there are some people who will get PML only from the one of these other medicines. That's between 1 in 5 and 10,000. Okay, and that's certainly more than would happen normally. The normal rate is about 1 in 75,000 people will get it, but it's 1 in 5 or 10,000, which means there is a risk to taking MS treatments, these more effective MS treatments. But let me tell you, the risk is you're going to get in a fatal accident on the way to the doctor more likely than you're going to get PML. All right. Let's talk about treating your MS naturally. Please treat your MS naturally, and please treat it with highly effective medicine. Natural treatment for MS does not treat the MS. It makes it milder. All right? It does not make it go away. If you want to make your MS really good, you treat it with natural things, and you treat it with highly effective medicines. There are lots of natural things. Not wanting to take medication, in many of these medicines, your body doesn't know the difference from your food that we give you. In many of these medicines, this blocks what we know is a harmful mediator that your body cannot control and that you cannot control with food. Exercise is great. Yoga is great. Lots of rest is great. Intermittent fasting is great. Being a vegetarian is fine as long as you get enough protein. It's very hard to do, and most can't do it. Eating less fat, less salt, less grease, and less carbs is all going to make you healthier, but it's not going to fix your MS. The person who wrote the book, who's a very smart doctor, got chemotherapy before she treated herself with her diet. Diet is great. Diet makes people feel better. Getting enough omega-3s makes your brain much more resilient and resistant to the damage from MS. Getting enough vitamin D is critical. It half lessens your disease. Keeping off high salty foods half lessens your disease. Eating fish from the ocean half lessens your disease. All these things help, but they do not fix the MS or stop it. We try to explain these things to people, and we can't always find an agreement with them, and they don't always want to treat their disease. And what happens is not good. Two things that are predictable will occur. The first is that people will have deficits that occur that cannot be made better, all right? And they often come back and try to get really highly effective treatments that actually do have a chance of improving people. Limtrado, Ocrevus, Tysabri will sometimes improve people, a minority of people, but they usually can't have the opportunity for that. But the insurers won't let them have those if they haven't had decent trials of other treatments. You're not allowed to have them. So you've sandbagged yourself, and you've ended up in a very difficult medical situation by doing that. So the situation is simple. Use a highly effective, safe medicine and treat yourself naturally. We want everybody to do that. All right. You need to measure your MS. There are lots of ways you can do that. You need to keep track of it. Your doctor ought to do it. The insurers won't pay him to do it, so you ought to do it yourself. Some will do it anyway. The disaster that's about to be Medicare because Congress won't take care of it makes it even more compelling. To measure your MS, you want to measure your cognition, you want to measure your hands, you want to measure your walking. People with cognition blame their MS. There's actually a lot of things that affect your cognition. The ones that are very important are medications. If you take tranquilizers or anything that makes your mouth dry or makes you sleepy, or you are going to have problems with your mind. That's the low-hanging fruit. The other thing is getting enough rest. If something's wrong with your rest, it's going to do that. The rest is due to your MS. You want to measure that too. But you can solve a lot of these problems. They're not beyond your reach. You can measure how quickly you walk, all right? From a standing start, a 25-foot walk with whatever gait aids you have to have. This is a very simple thing to do. This gives you an idea of how you're walking at a given time. And your doctor will do that. You can take this information to your doctor just like you can take a blood pressure. Your doctor may do this test, and kudos to them. It's a good doctor if they do this with you. But it's hard to do it every time. All right. The doctor uses scales that are like this in MS clinics. The EDSS is a very complicated scale. It takes an expert to do it. I can usually do one in about 4 or 5 minutes if I've already examined someone carefully and had them do a questionnaire. But you can't use these scales on a day-to-day basis, and they don't have a lot of meaning. You can see that someone could walk, between 100 and 200 yards, and their disability doesn't change. Well, if you were walking, 199 yards and you're now walking 100 yards, you would certainly think your disability has changed, right? Well, if you measure how far you can walk before you have to rest, that's a pretty good measurement to take to your doctor. It's very simple. You can also take it with how fast you walk 25 feet. All right, so we have this scale that you can fill out yourself, and it's called the Patient-Derived Disability Scale. It's from 0 to 9. This is the most important page because it's where most of you are if you got in here today. And it's just a number to put on how severe your MS is. And then the people with more limited difficulties are in here. Now, if you're already using a wheelchair or a scooter, this is not a useful scale for you. What's a useful scale? It's how your hands are working and how your mind is working. And you can buy this dexterity test called a 9-hole peg test online for $30. My colleague, Dr. Boster, has a video online of how to use it. There's several videos. The British were very big on this because they have those 3-minute neurology visits. You can test yourself in your hands. You do it 2 trials with each hand with a stopwatch. You put these pegs in a hole. Stupid, simple, very, very useful for measuring how you're doing. All right. There's another test that we use for cognition that's harder to do because you have to have the paper. Actually, you can get the paper online if you're resourceful, but it's copyrighted, so they don't like people to have it, and they don't like people to make copies of it, but you can find it online, the STMT test. And once you understand how to do it, you can have a friend administer it to you. All you have to do is you look at a series of symbols that look like that up in the corner, and you call out the numbers, and you have them write the responses down. And if you make a mistake, they will score it. But the number you get right in 90 seconds is your score. And a normal is more than 50. All right? If you're below 50, it's not normal. If you're below 30, you're very slow in your processing speed. And as I said, there are many things that can be done to improve processing speed. The things that we recommend for processing speed are just about anything that enhances memory and cognition. Memory testing is important. You can do memory tests online. The standard ones are done by experts. If you need disability-related testing, you need to see a neuropsychologist. They're much better at controlling the circumstances. You should do it. All right. These are my advice on improving your cognition. Fix your sleep, fix your mood, use coffee, strong tea, or green tea, moderate your alcohol, tuna, salmon, herring, or cod 3 times a week, cool your environment, consider an sphingosine 1-phosphate DMT. Those are the drugs like Gilenya, Zeposia, Mayzent, and Ponvory. And get off sedating medicines as much as possible, all sedatives and dry mouth meds, and treat your MS as aggressively. Do some exercise, is not on here, but exercise is the best thing you can do for your mind. If you don't do exercise, your mind doesn't get the hormones that it needs to stay good. Sleeping, melatonin, small doses improves people's sleep. Dalfampridine, the walking pill, wakes up your brain. The non-narcotic stimulants, modafinil, armodafinil do. Donepezil wakes up your memory. Bupropion promotes attention. Amphetamines surprisingly don't work very well, but we use them anyway. I like phentermine because it's a diet pill, and most CMS patients need that to cut their appetite. What about your MRIs? MRIs measure your brain. We can see brain volume. We can see disease activity. And we can see the size of lesions. Most places that don't follow the recommended guidelines for how MRIs are done. But when we talk about third ventricle and lateral ventricle size, this is space inside the brain. This is a normal looking brain. This is a brain with atrophy. This is a normal looking brain. This is a brain with atrophy. This space is bigger. This correlates very well with your cognition. We know this, and I just got a paper published that goes through using electronic software to measure the volumes of the brain tissue in these areas. And it's a very reliable way. It looks like we're finishing up here, so I'm just going to wind up here. The quality of the MRI has very little to do with how powerful the scanner is. It has to do with how the people run it. So I'm going to skip here. Don't forget your primary care. And doctors cannot examine you on a video link. If that is your only neurology assessment, it's inadequate. All right. Let me stop there because we're out of time, and we're going to take questions.
Great. Thank you very much. Anybody in the audience want to thank the doctor for speaking? I love when I get an audience response like that, right? All right. So who's got questions out here first? For everybody that's online, if you have a question for the doctor, I will be getting back to the screen in a few minutes. Does anybody out here have any questions? Anybody want? There you go. All right. You too.
What did you mean by burnout at 50?
Okay, so there is a lot of doctors who advocate stopping MS treatment when people are 50 because they say it doesn't work. The data that it doesn't work is based on studies that showed in the very few people that were actually studied over 50, it was harder to show that it had an effect on relapses. But there are many studies that show when people stop treatment, they get worse. And these have been done at 50, 55, 60, depending on whether or not people have changed the last 5 years or their MRI has been stable the last 5 years. So one of the catchphrases doctors have resorted to saying you don't want to treat people is your MS has burned out. It doesn't need to be treated anymore. And MS does not burn out. It declines in number of relapses, and the severity of the MRI changes as people get older. It smolders. There are what are called progressively enlarging lesions, which if you look at them, don't appear to be enhancing. But every time you look at them, they're just a little bit bigger. And that's the only thing you see on MRI, but people's disability is often worsening during this period. Their legs are getting worse, or their mind is getting worse, or their bladder is getting worse, or their sensations getting worse, because you can't measure all the lesions. And a lot of the lesions that are causing the problems are actually below the level of the MRI, or they're not seen well on the MRI. They're things that, because the way the MRIs are done, the abnormalities aren't easily appreciated. But that's what burnout means, or doesn't mean. Any other questions?
I have a question. You're talking about the importance of staying on therapy, and if you're doing well, it's probably because you've been on therapy. Some of the more higher efficacy therapies that are out there, like the tier 3 you're talking about, the B-cell depleters, how long would you say that you would keep patients on those medications? Because there's that controversy of having them on those and depleting those cells for too long versus switching them to maybe a tier 2 oral.
Well, that's a good question, because if you're on a treatment like Tysabri that the risk goes up and up every year, okay, that is something where most doctors will repeatedly try to switch people off onto something else. Now, that may fail, and they may go back to it, but then they can try again. And there are a number of things that can be tried to try to reduce risk. There are other higher risk therapies like Ocrevus, where the risk accumulates very slowly, if at all, or Limtrada, where the risk is well defined and can be monitored by medication, and people may not have to be treated for years. Same with a drug like Mavenclad in a lesser way, perhaps not as effective, but a very simple way to manage the disease. Things can be done that clean up the MS, and we have things that control the MS. So the difference between this is we have some medicines that are very good at cleaning up and some medicines that are very good at control, and we have lots of medicines that do a little of both. So the sphingosine 1-phosphate drugs are extremely well tolerated, work very well, but they are control. They are like putting the UN in your nervous system to keep the peace. And they keep things calmed down and keep the bad players out of there. You have other drugs that are like basically going in and cleaning out the bad guys, putting them all not in jail, but executing them. They're gone. If they come back, when they come back, we'll worry about it, okay? And then you've got lots of drugs that do a little bit of both. And so there are lots of ways, and we don't know what's going to work well for people in advance. But doctors who treat a lot of MS know that people who have really active disease need more treatments. But the insurers don't look at it that way. They look at it as, oh, you're costing us more money, or we don't like the fact that you have more risk. They always pull that one out when they don't want to pay the money. But it's in a general rule, you always try to move to lesser risks. Some treatments, I mean, you get 5 or 10 years out on something. What do? Well, we kind of start over at the beginning again. If it's gone really well for a long time, you can use treatments that are simple and have less risk.
Next question.
You were talking about a couple of different things, sleeping for one thing and using melatonin.
Yes.
And then you were also talking about weight gain too. What was it that you mentioned for that I could talk to
Could
my
you
doctor?
tell me the second part again about which?
The weight gain?
Waking up your brain. Okay. So
No,
waking
no, no,
up
no,
your
no,
brain.
no. She said about weight gain.
Weight gain. Oh, that's an amphetamine. Okay, so amphetamines are commonly used as appetite suppressants in weight management. Phentermine is a drug that's approved for that. If you go to a clinic that says we're a weight loss clinic, they give everybody phentermine. Okay, phentermine is like Adderall or amphetamine. It's an amphetamine. It is it has less abuse potential because it's very steady. It doesn't make people high in most cases. I mean, if you took an overdose of it, it would make you high. It's relatively safe. You can't take it if you have high blood pressure, uncontrolled blood pressure. It will make blood pressure or heart problems worse. So it is safe. But armodafinil or modafinil are non-narcotic stimulants that are approved for sleep disorders like narcolepsy or sleep apnea. The insurance company may not let you have it, approve it, but you can get a coupon and you can get it for $40 a month at a participating pharmacy retailer.
What did you say for the waking up of the brain? What was your
Well,
advice
a lot
for
of
that?
medicines wake up the brain. Now, bupropion, which is an antidepressant, is approved for weight loss also, and an antidepressant, and it's what else is it approved for? It's approved for several things. Wellbutrin was the old brand name for that. That is a drug that wakes up the brain. Dalfampridine, or it used to be called Ampera when it was a brand name drug, is a drug that was approved for walking. It actually wakes up your brain too, and these medications are in this family, and then. The medicine for Alzheimer's disease called donepezil, and medicines. There are a lot of medicines related. Most people take donepezil, and it makes your memory function better.
Thank you for that. All right, we got a lot of questions that are coming in online, but I want to let everybody know in-house and online that this will be on our YouTube channel in just about 10 days, all right? So whatever you did not remember that the doctor spoke about, you can check back. We'll let you know when it goes onto our YouTube channel, and you can refer to it at that time for your doctors or your friends or your family or whatever to learn more about. But in the meantime, I want to hit up on some of these questions that are coming in, all right? And so the first one, doctor, person wants you to explain exactly what a biosimilar actually is.
Okay, a biosimilar is the same drug made by a different company. And in order to make the same drug, they basically pull out the recipe for the drug biologic, like a piece of DNA that codes for the protein. A monoclonal antibody is basically is a way to engineer an antibody to make an antibody, for example, that your body wouldn't normally make. The way they used to do it was they would use an unfortunate laboratory animal to make that antibody, pull those cells out, squish them together with cancer cells so that they could find a cell that would make that antibody for them. But then they learned how to engineer these cells, and they stopped having to use unfortunate laboratory animals to make them. They just use cells that they cut and splice the DNA and get it into the cells, and the cell makes basically a designer drug. And this is how many of the biologic drugs today are made. They could engineer these, and so they know the DNA sequence. You can basically buy the DNA sequence. It's getting it into a cell and manufacturing that cell to produce those antibodies and showing the government that you can make that drug, and that drug works just the same as the other drug on the market. And then they will let you, if they approve your factory, they approve your drug, and they believe your data, they will let you make a biosimilar drug. And when you just put one biosimilar drug on the market, you know what happens? It's the same price, but two companies have that market. Once you get 4 or 5, then the price comes down. But this is just the way that intellectual property is handled in pharmaceutical manufacturers. The difference is these other drugs that are like dimethylfumarate, albagio, gelinia. These are small chemicals. These are things that any competent chemical engineer can make, and the government will do. They're shelf stable. They don't have to be made by cells. They don't have to be made in specialized sterile factories. Anybody can make it. In the third world, there's a million of these places that are churning these things out already. So it's not the same standard. It's like aspirin. Lots of people can make aspirin, lots of people can make ibuprofen, and it's the same for these MS drugs. They're going to always cost more because not as many, the market isn't as big, but the competition drives the price down. For Ampera, which is this walking drug, dalfampridine, which wasn't a simple thing to manufacture, and it's a highly toxic drug if you don't do it right. That drug used to cost $2,000 a month. Now it costs $80 a month. Why? Because a lot of people are making it, and it's equally good, and it's certainly adequate, and so that's the difference. Biosimilars will always be expensive, so biologics are going to be the hard drugs to get down the road with MS. Why is that? Because there's going to be a lot less expensive drugs, and there's only been a few now. Interferon beta, this old biological drug, is still there. It's not cheap. It costs just as much as everything else that's new. Why is that? Because people need it, and it's an expensive drug to manufacture.
Next one is Patricia writes, do I understand correctly that natural remedies as well as medication will not cure MS?
There is right now, the only thing that you could say might cure MS is some of these very aggressive chemotherapy followed by stem cell rescue treatments, and they don't reliably do that. And some of the other treatments, people can go many years. That's not a cure. That would technically be called a remission with MS. But repairing the disability of MS would be, I think, a cure. And very few people get their disability repaired with MS. You know, you have one brain, and when it's broken, it's broken. But things can function better. When you have optic neuritis, half of your optic nerve goes away, but your brain can compensate for that, and you can see pretty well with it. You don't see normally. You may think you see normally, but if we measure it, it's not normal. That's not technically a good repair, but it's a substantial repair. People repair their nervous systems when you control the disease. I see it every day on MRI. I could do a talk sometime for you about how to repair your brain. I've done it before. But the nervous system wants to repair. It will only do it if you stop the inflammation.
Great, thank you. Next one is from a woman named Jane. Did I understand that medication to sleep like Lunesta, for example, are bad for your brain? I've been on them for over 2 years. Please provide a short answer.
Yes.
Great.
Next. Did she really say that, Stuart? Yeah, anyhow, Lunesta and related drugs are sedatives. Lunesta is a better sedative than a lot of other sedatives, but they're sedatives. They mess with your brain. They make it harder to go to sleep if you use them regularly. This does not help people in the long term if we can't get them to sleep. There are other families of medicines. There is a drug called quetiapine that's often used for people who can't get off those sedatives because it wears off faster and it doesn't result in you having more trouble going to sleep. Melatonin, and there's a related drug called Ramelteon that's a pharmaceutical that works a little bit better, are drugs that do not sedate you but make you fall asleep more naturally. And there's another whole class of drugs that I can't even get to that are out there now that are quite expensive that will get you to sleep without sedating you with drugs that affect your mind. And the problem with sedatives like normal sleeping pills is they will make your brain not work well, and they manifestly change your disability cognitively tremendously, and people don't realize this. And we have this discussion many times, and people don't believe us till they get off the drugs.
Okay, next. a person writes, how will a chemotherapy drug or a person that needs it for cancer will it work for a person that has cancer if that same person has been significantly using it for their MS?
So we call on drugs chemotherapy in MS that aren't quite the same kind of chemotherapy that's used in MS. They're complex and they do involve removing cells, so they're called by that name. But in general, they don't interfere. There are medicines that we have on our list that we have used for MS that are actually used in cancer treatment, but in different doses or different regimens or in different settings. In cancer treatment, they come at it sometimes from many degrees at once. It doesn't bother the cancer doctors. They're not worried about it. Most doctors don't worry about it. You don't need to worry about it either.
Okay, thank you. Next one, all these different MS medications, when they're going through clinical trials, are they being tested equally on people of different races?
No, that's a good question. The answer is no, because the prevalence of MS is different in different races. People who are of non-Caucasian origin don't get MS as often as people who are Caucasians. Why is that? It's those evil Northern European genes that kept them alive for millennia in the cold, dark North. African immune systems were different. Asian immune systems were different. When you come to America and you intermingle and you interbreed with Northern Europeans, you end up with European genes, you get MS more. And you eat American food, which is probably not one of the reasons why we get MS. But all these people get MS, but anybody can get MS, but we can't get them into clinical trials and clinics with MS patients. So, I may have 20 or 30 white MS patients for every black MS patient that I have. And blacks have Northern European genes. So in the United States, they're not a pure African race. They are a hybrid race because of the unfortunate events that happened 200 years ago intermingled those genes. Probably not necessarily bad. I mean, they had to deal with European diseases, and so they got protection from European diseases by doing that. But now they get MS treatment, but they have some genes that are of African origin. In general, one of the weird things is people who get MS less often usually have it worse. We're not sure why that is, but that's true of men. But there are less men in trials. Of some trials, we can't even confidently say that the treatment worked as well for men because there weren't enough of them in the research study. But that's true for most ethnic groups outside of Caucasians. And Hispanics is an ethnic group. It's really not a separate group. And when you talk about South America, a lot of MS drugs are tested very well in South America. But South Americans are not a homogeneous genetic group. They are part European, they are part black, and they are part Native American. So this is quite a group. I don't worry about this as much because we're going to use whatever treatment the situation calls for. And the safety of these drugs is very well established. There has never been any concern about the safety of it in any of these groups. What the best treatment is in any given individual is not clear for Caucasians either.
Thank you. Next, can you tell us about AFOs? Which one you might feel is better?
Okay, an AFO is an ankle-foot orthosis. There are many gait aids. It depends on how much someone walks and how active they are as to what kind of gait aid they have. The person who manufactures custom ones is called an orthotist. Many times people are in with a physical therapist when somebody tries to fit them with an AFO. If you're walking 20 feet, you're going to get an off-the-shelf AFO that you strap on and you just make do. If you're walking hundreds of feet, you need an AFO that will adequately protect you, that you can realize. If your ankle is weak, you're at very high risk for two things happening. The first is you will trip on your toes because you don't get your foot up, or you will twist your ankle really so bad that you sprain it and you may be off it for 6 or 12 months, and if that happens to somebody with MS, they may never get back to walking again. So it's very, you're going to have surgery. You're going to have surgery and be off that foot for a few months at a minimum. So it's very important to have a good ankle foot orthosis, to have work with a physical therapist and orthotist to get it right. If you are very active and you walk a lot, you walk miles, or you're on your feet all day, you need a custom AFO. You may even want to get custom shoes. They make very lightweight ones for people who are very active, so it doesn't wear them out. But you're going to get whatever your therapist thinks you need and what your insurance company will pay for. But can you get a great one? Sure. You can get a wonderful one. People want these electrical devices that stimulate their foot and raise it. That's not the right way to treat a lot of people, but there are a lot of people who try to force you into that because they want to sell it to you. If your foot is floppy, that's probably a great device. If your foot is stiff, that's not a great device for you. So you need an expert to help you choose that.
Okay, thank you. We have about 6 minutes remaining before I have to get to the next speaker, but the next one is an interesting question, and that is, what's the best exercise for a person who has fluid building up in their feet while they're wheelchair bound?
Well, you can lay on your back and raise your legs, and you can lift your legs. So the muscles that get weak when you sit a lot are called hip flexors. They're the muscles that lift your leg. Your leg is plenty heavy enough to be all the work that muscle needs. And if you don't use that muscle, you will not be able to lift your legs. You will not be able to walk. So what I tell people who are in wheelchairs a lot to do is when they're sitting, lift their legs all day long. If they do that, they get amazingly much stronger. And it also helps your brain get stronger. The reason you get fluid in the dependent parts of the body is because the muscles pump the fluid that's drained out of the circulation back into the circulation. And if you don't use those muscles, you won't do that. Well, ideally you do it by walking. But if you don't have control over your calf muscles, you can't do it. The only thing you can do is raise your legs, wear support hose or a roller bandage to keep it down, or the least preference is to use a drug that makes you pee out the extra fluid, but that doesn't work very well because it'll just lower your blood pressure most of the time. The best exercise when you're laying down is lift your legs. If you can lift those legs while you're laying flat on your back, your legs get stronger, the fluid gets less, and your brain gets bigger and works better because you're exercising.
Thank you. Next one. How do I work on cognitive problems?
Well, you have to remember, number one, that you have a cognitive problem. Not like Paul. No, that's a joke. But there's a lot of things that you can do. The most important thing you can do for a cognitive problem is exercise. There's a hormone called BDNF that your muscles make. It makes your brain cells grow. That's the number one thing. The number two thing is you get off all these drugs that make cognition worse. And the number three thing is you use your mind, okay? You talk, you get out with people, you read, you concentrate, you try to do things. If you use your mind, if you exercise, and if you engage in people socially, it will get better. If your mood is off, antidepressants help. They help your thinking, they help your concentration. There are a lot of these other medicines that wake up the brain and make the brain work more. Getting enough rest at night. If your sleep is disturbed for any reason, your cognition will be off. It's so multifactorial. There is no one solution. You have to do it all.
Okay, thank you. Last one, I believe it's going to be the last one, and that is, why would the insurance industry knock you off of a brand medication when it's working so well for you versus the generic and risking relapse or hospitalization?
It's their money. It's not yours. And They will do whatever. This is why they don't let people have a medicine, is because they've done a deal with another company that gives them a better deal. Either it's a lower price, but more commonly, it's more money in rebates, which that they're horribly addicted to. We have insurers try very hard to prevent people in Blue Cross Blue Shield of Tennessee, which is one of the Blue Cross systems, is absolutely criminally trying to stop people from having Tysabri, Lemtrada, and Ocrevus because they don't get rebates from those drugs, and they want the rebate money so that they can pad their accounts. And it doesn't matter. They'll find some excuse to say that people can't have those. They'll create a policy where nobody can have it, and it's really maddening. Why do they do that? Because of money. It's all because of money. It's not because of what's best for you. It's not because of what the doctor thinks for you. You have to help. You have to complain to your insurer, ask for a case manager, file a grievance. You may have to try something else. They may say, we're not going to let you have this drug unless you've taken a methylfumarate, which is not an unreasonable thing from a cost point of view. But what you may have to do is go back there and show that you can't take it. You can't take that family of drugs. So your doctor may have to write a letter that says, you can't take that. You've got too many stomach problems to take that. That would be malpractice for you to take that drug. Sometimes even that doesn't work, even when you tell them that. But you've got to fight if you want that. Many times, if your doctor keeps fighting, the manufacturer will give you the drug for free, even for up to a year while they're fighting. All right. Thank you very much. Don't stop fighting.
So, you didn't let me finish. So there's a few people online saying that this is the best presentation they've ever seen. So I wanted to let you know about that, all right? And then we'll take it from there. If anybody had any questions for the doctor in person or online that we didn't get to your questions, I'm sorry for that. But, there's just a certain amount of time that we can do all these events. But if you want to, send an email to me, and I will send it off to the doctor, and I'll have him respond directly to you, right? There you go. Thank you. All right. So again, we want to thank all those that supported tonight's program. Again, everybody, good night.